All right, so like I said, this is Parkinson's disease, just brief overview of what the disease is, and mainly going to be talking about different medication and surgical treatment options. So starting off with what is Parkinson's disease? It's a term that I think a lot of people have heard. You may know somebody that has it or have it yourself, but there's a lot of different neurological diseases out there. So what exactly is specific about Parkinson's? So Parkinson's disease, there's several things that fall under this neurodegenerative categories. There are things like Alzheimer's disease fall under this large umbrella term, but Parkinson's is specifically a disorder that affects the dopamine producing cells in the brain, and they're in an area called the substantia nigra. And then because of this degradation of these dopamine cells, we know that Parkinson's patients actually have lower dopamine levels in the brain. And so this leads to certain symptoms that can result from this. We typically think of both motor, physical symptoms and non-motor symptoms. So in the black text here, I have the main motor symptoms, tremors. Not everybody has these, but that is a large portion of patients, how they'll first get identified is having a rest tremor, so more when sitting still. Then there's other types of tremors that are more with action, doing activities, but those are less likely Parkinson's tremors. And then the feature that you have to have that every patient with Parkinson's will have is actually the second term called bradykinesia, or having slowness of movement. So often this is noticed by the patient themselves or family members, their primary care doctor in their walking or gait, we refer to it. There's also typically components of rigidity, which refers to stiffness in the muscles, not in the joints. Obviously, as you get older, you can have arthritis in your joints, like your knees, your ankles, your hips, but this refers to stiffness in the actual muscles themselves. And then there can also be gait and balance problems that arise. And so these features I have listed here all fall under that motor category. And that's usually what'll first tip someone off to think about Parkinson's disease, but we also have dopamine does a lot in our brains. And so there's also these I have coming up in this blue font here, the non-motor symptoms. So constipation, this can be something that starts even many years, decades prior to other symptoms of Parkinson's disease. You can also have anosmia, which is a lack of sense of smell. Obviously, most people are kind of familiar with this idea after COVID, but we've been looking at this feature in Parkinson's for much longer before that. And there could also be hypophonia, means getting a softer voice, a smaller voice, more the literal translation, but having a softer voice than the patient used to have, or a little bit more muffled. That could be a sign also of Parkinson's. And there's also another condition that can affect sleep called REM sleep behavior disorder. So REM sleep is when you're dreaming, and usually in that state of sleep, the only thing that might move is your eyes. That's what they call rapid eye movement. But patients with Parkinson's can actually lose that stillness during dream sleep. They can have acting out of their dream, hollering out, kicking, punching. And so that's something that, commonly a bed partner, like a spouse, significant other, might notice, and not the patient themselves. So what causes Parkinson's disease? I already mentioned a bit about the loss of dopamine, but how many people get Parkinson's? So, and what, is it genetic? Is it not genetic? So there's about only 10 to 15% of cases are considered genetic. And that means that, usually you inherit those genes from either one or both parents. There's different types of genetic disorders, or more rarely, you might be the first person to develop a new mutation. There may not be anyone in the family, but these are quite uncommon. Most cases of Parkinson's are considered idiopathic. And in medicine, it's really just a term for, we don't know what the exact cause is. So you'll see that with non-neurological diseases too, that term idiopathic. But so 85 to 90% are spontaneous. That's the majority of patients I'm seeing. We do not think there's a genetic cause of the disease, and just more as you get older. So But there have been certain environmental factors that have been linked to increased risk of Parkinson's disease. And so sometimes your doctor may ask you about these things. So pesticide exposure. And I have a lot of patients ask like, oh, well, when I, do gardening, I've used, Ridex or different weed pesticides, but this is usually heavy pesticide exposure growing up in a rural area where maybe there was crop dusting, very, heavy pesticide exposure, not usually just what you would use in your own yard in a suburban area. Also well water usage, if you grew up and you had well water as opposed to city water, that's an increased risk. And this doesn't mean that everyone who had these exposures is going to get Parkinson's, it's just increased compared to the baseline risk. And then also if you've had a prior head injury, so, we can't know for sure, but you think of some of famous people that have had Parkinson's, like Muhammad Ali, obviously, even though he was a good boxer, there were, some hits in there. So we do know patients that have had traumatic brain injuries, boxers can have higher risk of developing Parkinson's disease. Now, what are protective factors? What are things that, we can more control? And so we have caffeine. So caffeine, it's, it's a bit tricky because there's other conditions, like if you have high blood pressure, that your primary care doctor or cardiologist may want you to avoid caffeine. But overall, caffeine is known to be protective for Parkinson's. So you do not have to cut out the coffee or something like that just for Parkinson's disease. Also uric acid, this is usually what's too high in people that have gout. And this is kind of interesting in the studies, only for men has it been shown that high normal levels have a decreased risk for Parkinson's. So overall does not, for women doesn't decrease it, but this really only comes into play. We don't really supplement with uric acid, but sometimes we'll have patients that previously had a history of gout on medications that lower their uric acid levels. And if their gout's been under control, we usually recommend just knowing this factor, that if the gout's been controlled, to maybe they can come off of the gout medication that's lowering that uric acid level. Cholesterol levels, there are lower rates of Parkinson's disease in people taking statins, which are the most commonly prescribed type of cholesterol medications. There's also evidence that statins can help with lowering dementia risk. This is most likely probably because the brain, if it has, different hits from different conditions. So having high cholesterol can make you more at risk for, kind of buildup of mini strokes, or we call white matter changes in the brain. And so if you have that plus a neurodegenerative process like Parkinson's, like Alzheimer's, it's probably going to make you higher risk. So it's not that necessarily the cholesterol directly affects the Parkinson's, but if you have two things working against you versus just one thing, it's going to increase your likelihood of showing symptoms of it. Exercise, this is the thing that we most have that we know can help reduce the risk of Parkinson's. And then also, even if you already have Parkinson's, it's the only thing that we know can slow progression. There's certain diseases that have already disease modifying therapies, meaning treatments that will actually slow progression of the condition, but Parkinson's is not in that realm yet. There are ongoing studies of medications that hopefully can slow down the progression. But the only thing we know already that can help with that is exercise. So who gets Parkinson's disease? It's going just over some statistics of the population that typically gets it. So there are nearly 1 million people in the US right now that are living with Parkinson's. So it's a fairly common disorder. And as you get older, your risk increases. So, as you usually by the time if you live a normal lifespan for the US, predicted at least, around 80 years old, about 1 in 100 people, like 1% of people by that age will have something like Parkinson's. And as you get, even older, that rate increases. And so, with a population that is getting older in the US, we expect that number to rise to 1.2 million by 2030. And there's about 60,000 Americans diagnosed with Parkinson's each year. So every day, you divide that every day, obviously, we're giving a few hundred people, between all the neurologists of us practicing, a diagnosis of Parkinson's. So, it is something that usually you will know someone in your lifetime, whether it's yourself, a loved one, a friend, that has the disease. Most people get Parkinson's after the age of 60. That's kind of our typical age range. And like I mentioned earlier, the older you get, the higher the chances that you develop something like Parkinson's. But there is a small percent, about 4% of patients who are diagnosed before the age of 50. You can think of kind of the probably most widely known celebrity that has Parkinson's disease, Michael J. Fox, who's done a lot of great work with his Foundation for Parkinson's Research and Advocacy. But he falls into this small group of patients that get it before the age of 50. Again, I don't know his personal case, but those patients are more likely to be genetic causes when they get it before the age of 50, but not in every case. So usually we think of older patients that get it being the more sporadic, idiopathic type, and then younger patients more likely to be a genetic type of Parkinson's disease. And there is a difference in gender as far as who gets Parkinson's. So men are about 1.5 times more likely to get Parkinson's than women, but still lots of women that get Parkinson's. And so I see, patients of all genders. So now for kind of what the majority of the talk is going to be about, I'm going to get into what are some of the different treatment options for Parkinson's disease. And it kind of all this slide, don't worry, this is a slide that is pulled from a textbook that I use when teaching a lot of med students and residents. So don't worry about trying to understand the graphic completely, but basically it's just to give a pictorial representation of what we're trying to do with a lot of these medications. So in your brain, you have different neurons, and they're trying to communicate with each other through chemical, electrical signaling in these areas, these spaces between. So each different colors you can think of as a different nerve cell. And so dopamine here, this is the main chemical involved, and we're going to talk about all these different classes of medications a little bit, and how they work, but the mainstay is trying to effectively give more of this dopamine stimulation back to this area here where it binds to these receptors on the ends of the cell. So we're trying to we know Parkinson's is caused by loss of these dopamine cells, so we're trying to give back more of that dopamine stimulation to improve the Parkinson's symptoms in the majority of medications we have currently. So the mainstay is carbidopa levodopa. It is a mouthful if you haven't heard the drug before. So, usually I don't make my patients say this whole term. We'll usually maybe just use this part, levodopa, or even dopa. I'll know, we'll know what we're referring to. So this is a really long word. It's a generic drug, but I'll go through kind of why it has that name as we go through. So it's been around a long, long time. It was developed in the 1960s. It's still a mainstay of Parkinson's treatment, even though it's been out all these decades. And I told you that Parkinson's is missing dopamine, but why don't we give pure dopamine then? Why don't we just give dopamine? Dopamine cannot cross the blood-brain barrier, but this levodopa that's here can. So this is able to, go through your gut and get absorbed and actually get to your brain, unlike if we gave just pure dopamine. So this levodopa gets converted. And then this part of the medication, this carbidopa part, dopamine also has other effects. Levodopa getting, if it does, some gets converted to dopamine earlier in the digestive process. It could lead to side effects like low blood pressure, nausea. And so this part, this carbidopa part, tries to help prevent this levodopa from turning into dopamine where you don't want it. So it's trying to get as much of this active part to the brain as possible. And this is just a picture here, like I mentioned. So we give levodopa, and then it enters into the brain. And then here, your brain already has the necessary enzymes to break down this levodopa into dopamine to give the brain back what it's needing. So it works. It is a prescription medication, but it works very similar to taking a supplement. The only thing is we have to, do this step where the levodopa gets converted to dopamine, but it's really just giving the body back something that it's lacking. So it's still our mainstay treatment, but a pretty simplistic way that it works. And then this is demonstrating how the carbidopa component helps this yellow section, supposed to be the rest of your body other than the brain, how this carbidopa part helps block it, the levodopa from converting into dopamine where you don't need it, and it could cause some more side effects. And so carbidopa levodopa, it is still the mainstay of our treatment, but it's available in a lot of different formulations these days. So a lot of these are generic. There's an immediate release version, an extended release version that are both generic, but there's also a combined form of the immediate and the extended release formulations called Rytary that helps keep the dopamine levels relatively stable in the bloodstream. Unfortunately, none of these formulations can be taken just once a day or usually even just twice a day. Usually, even after all these years, the way dopamine's broken down in the body, you have to take these at least 3 times a day. Some patients even taking 4 to 5 times a day. So, it can get a lot of pills eventually to manage, but this still tends to have the strongest response in improving those motor symptoms that I mentioned earlier with tremors and stiffness and slowness. This still tends to be the best medication for that. And this Rytary is a brand name, so it can be expensive, but usually most insurance plans, thankfully now, we can get it covered at a decent rate. And like I mentioned, I do have to unfortunately dose these multiple times per day. And you can still unfortunately see this if you look online. There's, thankfully not websites like Parkinson.org that are widely vetted and read through, but there are still unfortunately old literature you can find online. And some doctors too, if they're not a Parkinson specialist, might think that it's good to delay the use of carbidopa levodopa until you're later in the disease stage of Parkinson's. But there's no evidence in kind of more modern studies that you need to hold off on giving the carbidopa levodopa. So if the symptoms are starting to get severe enough to affect quality of life, I will, go right away to carbidopa levodopa, especially as you see, as I talk about some other medications. Some of the other medications in older patients can have higher risk of causing significant side effects. So, as Parkinson's, there's nothing disease modifying yet. So nothing's slowing progression other than exercise. So you don't have to start medications until you need them to control symptoms, but there's also no harm in starting something like carbidopa levodopa early on. It's not going to speed up how fast the disease progresses. All of these carbidopa levodopa formulations can lead to some side effects of nausea, fatigue, lightheadedness. That carbidopa part tries to prevent that from happening, but there's still a risk of these developing as side effects. Okay, so our next class of medications that is still very frequently used, not as much for older patients, but if you're on the younger side when you get diagnosed with Parkinson's, are called dopamine agonists. And so if you can remember a little bit back to that graphic, these are not giving pure dopamine back to the brain like carbidopa levodopa, but they're stimulating those same receptors. So they're still stimulating dopamine in the way that they work. So these drugs will bind to those little kind of rectangles you saw jutting out where in between the spaces that will stimulate to make the body think effectively it's getting more dopamine without giving it directly. And so these medications are not just used for Parkinson's, they're also used for patients that have restless leg syndrome. And so, you may have yourself, friends, family members that are familiar with some of these medications for that indication as opposed to just Parkinson's disease. There are several types on the market. There are two that are in tablet forms. I have both the brand names and the generics here. So the brand names being Mirapex and Requip, which are pramipexole and ropinirole. And these medications have both extended release options and immediate release. So these are good medications. If you are someone with more mild Parkinson's symptoms and taking a medication 3 times a day is going to be tricky. These immediate release ones are still usually dosed 3 times a day for Parkinson's patients, but both of them having the extended release options, those can be dosed 1 time a day. And there's also a patch version of this dopamine agonist type class. And this is really, if it's covered by the patient's insurance, a nice option because it's just once a day wearing a patch. It releases continuously. The patch is designed well, called Rotigotine Nupro. It's still only brand name. These 2 pills are both available generic. But if this can be for not cost offensive, this is a nice option too, available in several different dosing strengths of this medication. So these dopamine agonists, they can help reduce these motor symptoms as well, but a max dose of these is not going to be as strong as the first thing I mentioned, the carbidopa, levodopa. So these are good tools to use, and I have some patients that are on just these for several years, but usually eventually everyone with Parkinson's is going to need to try that first class that I talked about, the levodopa formulations. And we do have to monitor side effects on these dopamine agonists because there's some strange side effects. There's some typical things like nausea, but it can also lead to leg swelling, discoloration. And then the more kind of serious side effects that we have to counsel about and monitor are that it can affect cognition sometimes, causing confusion. Not all Parkinson's patients get hallucinations, but can increase risk of hallucinations, especially if given to patients over the age of 70. And then they also have a very odd kind of side effect risk. It's very uncommon, but when it happens can be severe, of causing impulsive behavior, impulse control disorders. So things like gambling, pornography addiction. So it can have some online shopping addiction. So it can have some serious side effects that we do need to counsel for, and usually make a family member aware of as well to look out for, because sometimes the person taking it themselves may not realize they're starting to get these impulsive type behaviors. And so these, like I mentioned, usually reserved for patients less than 70 years old because of the risk for confusion, hallucinations. However, the impulse behavior, that can happen at any age. So these usually are what we'll use in younger patients at first, but they're still at risk for those impulse control side effects. So just have to make sure we're monitoring and counsel for that. And then we also have medications, like I mentioned, these carbidopa, levodopa medications, they work pretty well, but they do wear off. We have not been able to figure out how to make a once a day or even twice a day formulation of any of them. So we have some medications that actually can help extend how long they last to kind of inhibit some of those enzymes that break down the dopamine in the brain. And so by blocking these enzymes that are usually degrading the levodopa, then we can make it last for longer. These have been out for many, many years, but they do have some newer formulations. So the MAOB inhibitors include rasagiline and selegiline. And these medications can be used either alone or with carbidopa, levodopa. So there are some patients early on, especially with the rasagiline, because the rasagiline can be taken just once a day, so it's fairly easy to use, low side effect profile, not so much robust benefit, but if symptoms are mild, you can just take this once a day medication, and you do not have to start levodopa for these. They do have a newer MAOB inhibitor that blocks, this is the enzyme name that it blocks this, called safinamide or Xadago. This one is approved as just an adjunctive therapy, meaning you need to be on carbidopa, levodopa already. And then this one can be added to make the medication last longer. It's just a once a day medication. So these, these are decent options. They can have interactions with wines and certain, like they say, some of the stinky cheeses. So the enzymes they work on, sometimes we do have to make sure we're looking for drug-drug interactions or certain dietary things you have to look out for. Usually these have to be held if you're having a scheduled surgery. A lot of times anesthesiologists will want these held for about 5 days before surgery. So there's a few things to monitor for, but overall fairly safe class of medication. And then the other enzyme inhibitor is the second one, COMT inhibitors. These are used with carbidopa, levodopa. So they're not going to really give any benefit on their own. But if they're taken with the carbidopa, levodopa, again, can help extend how long it lasts for. And there's entacapone, which has been on the market for many years, available generic. And that one has to be taken with each dose of levodopa. So typically taken 3 times a day at the same time. They do make a formulation that's generic combined already with the carbidopa, levodopa into one pill. When it was still brand name, it was referred to as Stalevo, which they kind of came up with like stay levodopa. So they did good marketing with how they came up with that name. But this is a formulation available, but we also do have a newer one if it gets complicated to take the dose with every dose of carbidopa, levodopa. They do have one of these COMT inhibitors called opicapone that just has to be taken once daily in the evening time. It is still brand name. So, all these newer medications, we have to make sure we can see if we can get them affordable. Medications, more class, we have amantadine. And this is a unique medication. It was originally developed actually for flu prevention, and doesn't work for the flu anymore as the flu has mutated over the years, but it does work for Parkinson's. And the way they figured this out was that they were giving it to patients in the 1970s in nursing homes to try to prevent the flu. And then patients that just happened to have Parkinson's, they noticed that their tremors were doing better. So was not designed specifically for Parkinson's, but used still quite a bit for it. And this is one that can be used alone or in combination with carbidopa, levodopa. So has decent benefit, especially for patients with strong tremors. So that's usually where I'm using it the most. But it also can help with the other symptoms like slowness and stiffness. And then it can also be used, this is the only medication that we have. Parkinson's patients, as they've had Parkinson's disease, usually for at least 7 years, sometimes can start earlier. They are, not everybody, but some can develop abnormal wiggling movements, kind of dance-like wiggling movements that we refer to as dyskinesias. So this is one of the only, really the only medication we have for Parkinson's that can actually help reduce those abnormal movements. The rest of our medications can actually potentially worsen those abnormal movements. And so this medication sometimes is added early on for treating the typical Parkinson's symptoms, but also sometimes added on later to try to treat those dyskinesias that can be a side effect of our other treatment medications. This is typically dosed between 2 to 3 times per day, but it can be given at the same time as carbidopa, levodopa. And side effects can include leg discoloration, but again, confusion and hallucination. So this medication, I do have some older patients on it that we're trying to treat the dyskinesias. But if it's just for the main symptoms of Parkinson's, usually I do not use it in patients over the age of 70, since there's other options that are less likely to cause the confusion and hallucination side effects. They do also have this medication available in an extended release form, still brand name, called GoCovery, and they have Osmolex. Now GoCovery bought out this company, so it's going to be pretty much just GoCovery now if that form is used. But I checked last night. It looks like there's still some Osmolex on the market, but probably it's going to be going to just this one. And the nice thing about this medication is that it has 2 FDA indications. So one for these abnormal wiggle movements that can develop called dyskinesias, but also for treating off episodes. And what that is the longer you've had Parkinson's, there might be more times where your dopamine levels are fluctuating as your brain loses more of its natural stores. You can be more prone to times where you feel really good, where the medicine's working, we call on times, and then off times where the medication is not working. You might feel stiff, slow, a lot of tremors. So this medication can be added once a day in this extended release form to help reduce both the wiggles, if you have that as an issue, the dyskinesias, and also help reduce off time. So give you a smoother course throughout the day of feeling like the medication's working well. And then we have a few more that are fairly new to the market within the last, I want to say 5 years, but I think it might be, yeah, I still think this one's within the last 5. It came out, I think, right before COVID. So Norians, this one is unique in the way it works. This is the only one that doesn't really work on the dopamine pathway. This works on inhibiting adenosine, and this is what caffeine inhibits too. So this is why they knew caffeine was helpful for Parkinson's. So this company basically created a drug working on that same effect that you would get. And so this helps to block some of the adenosine rather than working directly on dopamine. And this is also in that adjunctive class. So you add it to whatever your prior regimen of carbidopa, levodopa, dopamine agonists is. And it also helps to reduce those off times. So hopefully giving a smoother course throughout the day where you don't feel the medicine kicking in, wearing off. It's just dosed once daily. And like I said, used in combination. And the side effect profile, I still listed them here, but fortunately it's pretty low. This is quite a safe medication to use, especially in more geriatric patients. It can increase the risk of those wiggle dyskinesia movements and some kind of typical listed side effects you might see on drugs like dizziness, small risk hallucination, but to a much lesser degree than the other drugs I mentioned. So, so this is it's a kind of a mild effect as far as how many hours of off time it reduces per day, but it's still quite a gentle option to add on. This is one of the oldest Parkinson's medications, trihexyphenidyl. It's not used that much in practice anymore. Also does not work directly on dopamine, works on a receptor called acetylcholine, but you might still see this used sometimes. And there are some neurologists I've seen that refer to me that still use this maybe as their first line medication because it can help reduce tremor. It can also help to reduce a condition called dystonia, which some can be its own condition, but also seen with some Parkinson's patients. And those are, dystonia refers to abnormal muscle contractions. And so, but this medication, compared to kind of everything I've talked to you about, this one, the way it works on this acetylcholine receptor blocking this really can increase risk for memory issues, hallucinations. So of all the things I mentioned that we might try to avoid after age of 70, this is kind of the one we most really want to avoid in older patients typically, because a lot of Alzheimer's drugs actually work to help that receptor not block it. So it's really working against cognition the way it works. But in younger patients with a strong tremor, it's still an option that can be considered. Now, there are also several rescue medications. So like I said, later stage Parkinson's, you can have these periods of fluctuations, medicine's working really well, and then you wear off. We call those off periods. And so there's several medications that are on the market to help treat these off episodes. Maybe you need something that works faster than your regular pills of carbidopa, levodopa to help you get over these severe off episodes. So there are kind of there's still 2 main options. There's still potentially a third option available in the US. There's one called Inbrija, which is an inhaled form of levodopa. So still levodopa, but can get to your brain faster because it's in an inhaled powder, as opposed to the pill needing to digest through your stomach. And it looks kind of, this is a picture of it. So you get this inhaler and you get these capsules that load into here. Fairly easy to use. Sometimes patients might report some chalkiness because it is this chalkiness feeling in their throat because it is an inhaled powder. So usually recommend drinking some water with it, but it does work usually, within 15 minutes. It works pretty fast to help the patient feel back more normal and get their dopamine stores up. There's also Apokyn, which is still available on the market, been out for a long time. This is an injectable apomorphine. So this is that class called dopamine agonist that it's not levodopa, but it helps stimulate the same receptors. This is an injectable pen. And so you do have to have, either the patient comfortable with using it or a family member that's comfortable doing the injection for the patient. But it's an injectable, so it works, again, quite fast. Now, this one hit the market, but didn't really do well in the US. So it's still available somewhat in the US, but more for patients already on it. It's hard to get newly prescribed in the US. It sounded like a really easy way to give. It's a sublingual, so it really looks kind of like a Listerine patch. But the issue with this one, why I don't think it took off as much in popularity, is it does have a risk of dropping the blood pressure quite significantly. To start it, these two we can just prescribe patients. They can start at home on their own. This one had to either have nurse monitoring or physician monitoring. The drops in blood pressure and nausea could be that severe. So this one is kind of less likely probably going to be recommended by your doctor, harder to get in the US. They're still selling it in other countries and still somewhat available in the US, but limited. There's also, like I mentioned early on in the talk, there's a lot of non-motor symptoms in Parkinson's. And so, what are some of the things we can do for those? So later stages of Parkinson's can lead to issues with orthostatic hypotension, which is decreased blood pressure. Usually you feel kind of dizzy, lightheaded upon standing. And so there is a drug called Northera that was specifically developed for that. We do also use older off-label things like midodrine that help to raise blood pressure, but this one is developed specifically for neurogenic causes like Parkinson's, so neurological related causes of orthostatic hypertension. There's also Nuplazid, and this is a drug, I think it hit about 2016 or so. It's been on the market less than 10 years. And it's called pimavanserin, although it's only available branded so far. But this is a big kind of unique drug in the market for some, not all patients with Parkinson's develop hallucinations, but there are a certain percentage that do. And so for those patients that the hallucinations are becoming bothersome, we used to only have antipsychotic drugs available, which can actually worsen Parkinson's motor symptoms. So this drug was nice. It was developed specifically for Parkinson's patients to help with their hallucinations without blocking any of the dopamine. So still letting the motor symptoms be controlled, no counter effect of this medicine with the main treatments of Parkinson's. And then there's several medications on the market available for memory, and I use really a mix of all of them, depending what the patient tolerates the best. But the only one that has FDA approval specifically for Parkinson's dementia, and again, not all Parkinson's patients get dementia, but as you get older, your dementia risk goes up, and same thing in Parkinson's. Older Parkinson's patients have higher risk of that. So rivastigmine is the only one that is FDA approved specifically for Parkinson's disease. And this is available both in a tablet and a patch formulation. So not all insurance plans will cover the patch, even though it is generic, but it's a nice option if you're already feeling like you're taking a lot of tablets already, and it's a 24-hour release patch, so gives it also kind of continuously the medication. Surgical treatment options. This is something that we do a lot of, where I work in the medical center with UT, but also obviously a big city like Houston, we have few groups in town that are big into surgical treatment options. And so the one that's been around for the longest is deep brain stimulation. And it's been FDA approved since 1999, actually. So over 20 years now that it's been available. There's also focus ultrasound, which is newer to the market. And I'll talk in detail a little bit more about each of these. And then there's also a Duopa Pump, a continuous levodopa gel that is absorbed a little bit past the stomach in the gut. So we'll go a little into each of these. So deep brain stimulation. This originally, when it came out, was thought to be a treatment reserved kind of for late stage Parkinson's, but the more updated studies show that probably earlier implantation is better. And so it can be considered actually in someone that's had Parkinson's for at least 4 years. Not all patients that have only had it for that amount of time. Not everyone 4 years in is going to need this surgery if they're doing well on just oral medications, but it can be considered as soon as 4 years into the disease. It's for patients who have motor fluctuations despite, best efforts to properly dose their oral medications, try different formulations. They still have refractory, maybe tremors or just severe off episodes despite use of the current medications that we have. Because this deep brain stimulation is able to provide constant stimulation. It can help all of the motor symptoms. So tremor, bradykinesia, rigidity, it's not going to help the non-motor symptoms. And it also can help reduce dyskinesia. So some patients that do well with the medication as far as not having tremors or stiffness or slowness, but get a lot of side effects of those wiggly dyskinesia movements, this is a good way to balance that out, because unlike our medications, this can be used to help with both the motor symptoms you have from Parkinson's itself, as well as the potential side effect from the medication, the dyskinesias for abnormal movements. And I do see one question there that I'll get to at the end. And then the workup for this, you do usually get a memory test done before. You can have some memory changes and still be a good candidate. It's just the research shows that if you or someone that has already a full-blown dementia syndrome, you're unlikely to benefit. And it's, a safe surgery, but a big surgery to go through if you're not going to get benefit. And then we also do called on-off testing in the clinic. This is with your neurologist. And we have the patient come in off of their medication early in the morning. And we do a full exam, and we score more points means more symptoms. And then we have the patient take their medication and wait for it to kick in, which usually kicks in very fast within 20 to 40 minutes. And then we repeat the exam and make sure there's at least a 30% improvement. And this is just because we know that the deep brain stimulation is not going to work for patients who don't respond to medication. So the deep brain stimulation can help smooth out your day, can help refractory tremors that do not respond to medications. But if you're not a responder in general to medications, then for Parkinson's, then this is not going to be a good option for you. And there's two different potential targets. I'm not going to, for sake of time, belabor this too much, but there's a subthalamic nucleus, which is the more common target and usually used for tremor control. Also, if you're someone who needs a lot of medications, it can help decrease how much you need for that. And then there's also globus pallidus interna, which is best for patients who have a lot of those wiggle movements, even with a low dose of carbidopa levodopa, and also is less likely to cause any memory issues, although both are thought to be safe from that standpoint. But it just depends on your neurologist and your neurosurgeon if they're going to factor cognition into their target or not. But by far and large, most of our patients are getting STN unless there's specific reasons to do the other target. And it's performed in 2 stages. The first stage, the surgeon puts in the electrodes in the brain, and then they do intraoperative testing to make sure they're in the right spot. And you usually spend just 1 night in the hospital. And then the second stage is when you get this battery pack put in your chest. If you have or know anyone with a pacemaker, the battery that runs this DBS is about the size of a pacemaker. And that's when they put the battery, they'll connect the wires. That's just a day surgery. So this whole process, even though it sounds really big, usually just spend 1 night in the hospital, and then 4 weeks after the first stage, 2 weeks after the second stage is usually when you come back to your neurologist's office to get the system turned on and programmed. The system is able to be programmed over time with adjustments made. So as symptoms change over time, your neurologist can also adjust your deep brain stimulation settings. This is an example of a patient with a strong tremor before and after deep brain stimulation.
Can you hold it, don't hit the counter there, but hold it like this.
And then this is after so this is the same day, as you can tell by the t-shirt, but this is before we turned on the system permanently. And this is after we turned on and programmed. All right, focus ultrasound. This one is FDA approved for tremor control. It works pretty well, just like you saw the DBS video. And it's non-invasive. So for some reason you're not a good surgical candidate, it might be an option for you. There's no incisions or anesthesia used for this one. You wear, it's still done with a neurosurgeon, you wear a special helmet that sends a focus beam of ultrasound energy to the correct part of the brain to kind of create a lesion where the tremor is coming from. The main drawback why I don't have a lot of patients doing this yet is that it can only be used on one side of the brain. And Parkinson's, while there's usually always one side that's more affected than the other, it's always spreads to both sides eventually. And so that's the main drawback. Eventually, the company that makes this is hoping to get FDA approval for both sides. And then I think it will probably be more popular. But right now, we've only had a few patients in our whole group here at UT that have gone with this option because of that limitation. You do also have to shave. It's kind of interesting for deep brain stimulation. Most neurosurgeons can now do it where you don't have to shave all your hair off. They can spot shave very small patches, but for focus ultrasound, for the helmet to fit properly, you have to shave all your hair off. So, depends on the patient, but some patients, they definitely don't want to shave their hair off for the surgery. So that's also, it might sound, minor, but for many patients, that's a drawback of this one as well. And this one is irreversible and permanent. So the deep brain stimulation can be adjusted over time. You can actually, this is very rare for someone to do, but you can actually take those electrodes out even. So it is considered a reversible surgery. And the last surgical option is the Duopa Pump. And this is helps deliver carbidopa, levodopa directly to the gut in the form of a gel. And so this can help keep symptoms more stable. And it can be used in conjunction with the other surgeries. There's not many patients that have both, but you can have DBS and Duopa Pump, or have had the focus ultrasound and Duopa Pump, because this is all kind of just surgery around the gut area. It does require the placement of a PEG J tube. So if you've ever known anybody that's had a feeding tube, this is not, you're still going to be eating normally, but that's about the same area the tube would go to deliver the levodopa gel. But the J stands for jejunum. So it's just an area a little bit past the stomach is where this is delivered to. And so this is like in a cassette that either the patient or a family member changes out once a day, and it runs for about 16 hours during the daytime, doesn't run overnight, and can deliver a constant level of dopamine. So this helps patients. Some patients may not, later in the disease, may not absorb their carbidopa, levodopa that well from their stomach anymore. So this is a decent option for that. It's bypassing and going just a little bit past the stomach, and this gel formulation usually is absorbed better than if you have to take the pills and go through. The main drawback is you do have to have this, exposed tube in your abdomen area. The tube has to be replaced every few years to keep the tubing stable. And then you do have this is a cartoon drawing from the company, but you do have to have this pump. And this is about a good concept of the size. So it is a decent size on this little cartoon man here. This is kind of an accurate representation of the size of the pump compared to the body of most people. So the company is working on hopefully getting the pump a bit smaller, but usually you do have to wear kind of almost like a fanny pack or different bags to hold the pump while you're up and walking around. And then, therapies are a huge part of Parkinson's management. So physical therapy to maintain balance and strength, occupational therapy for fine motor skills, speech therapy to help with both the hypophonia, the soft voice, and if there's any dysarthria, slurred speech. So these are usually done early on. Also, if there's swallowing issues, we can use speech therapy for that. So usually we do a course of therapy specific for Parkinson's disease early on in the disease, but also usually insurance companies will allow us to do it once a year. So not everybody needs a refresher course once a year, but that's a good option. Always more therapy is better. And it's really the only thing that can help balance. None of our medications really can address balance issues. If there start being, falls or fall risk later in the disease, this is the mainstay to help with that. And like I mentioned earlier, exercise, the only thing we know that can help slow progression. Specifically, this is aerobic activity. So I think lifting weights is still great for bone health and reducing, fracture risk, but for your neurodegenerative conditions like Parkinson's, you do have to get in your aerobic exercise. They recommend 150 minutes per week, which if you divide that into 30-minute blocks is 5 times a week of 30 minutes. But the studies show that it can be a wide variety of exercises. So things just like walking, running, cycling, swimming, dancing, really anything that gets your heart pumping. They even included gardening in one of the large studies that looked at exercise in Parkinson's. So you can get quite creative on what your type of aerobic activity is. And so now I only have one question in the chat box currently, but please, if anybody else has questions, feel free to write them. So I have one about asking if I can provide more detail on the leg discoloration, confusion, and hallucinations. So there's kind of two medication classes that can lead to those symptoms. So one that I mentioned are those dopamine agonists, and they have some nice features like early on, they can be used once a day. There's generic versions of extended release on those. So the leg, that one is more leg swelling. The leg discoloration one is more unique to the one called amantadine. The one I was saying was originally developed as an anti-flu medication. These are rare. These leg swelling and discoloration are rare, but occasionally we'll have patients come in that say, I don't know why my legs are swollen. My PCPs looked at my heart's fine. Why? And, then if there's nothing else that's a clear cause, it could be from one of those medications. Leg swelling, it really just depends how bothersome it is. It doesn't mean we absolutely have to stop the medication. If you get the leg discoloration with the amantadine, it usually looks like a purple, they call violaceous rash, kind of spiderweb-like looking. That one usually is recommended. It's called Levita reticularis is the name of that rash. And usually it is recommended that we stop it. The confusion and hallucination side effects, almost everyone will want to stop for that, the patient, the family member, because those are obviously usually affecting quality of life significantly if you're, and I don't think I clarified earlier, but Parkinson's hallucinations typically are visual. So seeing small animals, small people, unlike primary psychiatric hallucinations that are usually hearing things that are not there. Parkinson's typically is seeing things that are not there. So, that's especially if an older patient, maybe they used to be able to tolerate those medications earlier in the course of their Parkinson's, but now we have hallucinations popping up. The first thing I do before I would add a medication specifically for hallucinations is try to see if we can get the patient off medications that could potentially be the cause of the hallucinations. So like those dopamine agonists or amantadine that I mentioned. So I don't know if whoever wrote that, if you had any further questions, feel free to type, or if there's any, I don't see any other questions, but if there are any other questions.
I did get one personal message about how they can improve the quality of life for somebody with Parkinson's.
Yeah, so the quality of life is actually how most of these therapies end up getting approval, FDA approval for Parkinson's. Like I mentioned, these treatments so far, there are studies going on right now to see if there's drugs that can actually slow progression. But so because none of the current FDA approved things slow progression, they get approved because they improve quality of life scores. And so for every patient, it's going to be a little bit different what's needed to improve quality of life. If it's a lot of motor symptoms, they might need adjustments on their carbidopa levodopa regimen and our other mainstay Parkinson's medication. Sometimes I didn't talk really about this at all in this talk, but with lower dopamine levels, depression and anxiety are things that can be seen a lot with Parkinson's. So sometimes improving quality of life is addressing those symptoms with antidepressant medications, or even sometimes just replacing the dopamine sufficiently will be enough for the mood as well. Physical therapy, besides helping with just speech therapy, besides helping with those features of balance and walking and swallowing, just the social aspect too of that can be really good. The exercise again too for quality of life, the group classes, and someone also just added, do I know of any support groups in the Houston area for Parkinson's disease patients and caregivers? So the biggest one that's in Houston area, which can also help it depends on the patient, but sometimes having that community is helpful too. And so there's called the Houston Area Parkinson's Society, or HAPS, HAPS. And that is the biggest support group in Houston. They have different branches in different parts of town. It's a free resource. Everything's free. They have free classes. Obviously, your YMCA puts on events too, but this is a good, but the HAPS is also good for finding free resources in town. Let's see, Parkinson's does not affect executive function or cognitive ability, ? It actually can, not everybody, but it can affect cognitive ability in about 1/3 of Parkinson's patients. The risk increases as you get older. So, it's hard to say, is it just because you're getting older? How much is a Parkinson's? Although the memory changes are slightly different than we would see with diseases like Alzheimer's, and it can affect executive function. That can be one aspect that is affected in Parkinson's disease. Parkinson's disease does not affect cognition to the severity of one of its cousin diseases called Lewy body dementia. They are different diseases. So usually the cognitive changes in Parkinson's are more mild and manageable than in things like Alzheimer's or Lewy body dementia, but it can, in about 1/3 of cases, eventually lead to that. But usually cognitive changes should be later in the disease, not early on with Parkinson's. And then the second part of this question says, is Parkinson's progressive and not reversible? And yes, there is nothing right now that besides exercise that can slow progression. So it will get worse over time. Thankfully, it's very slowly progressive. So most patients live 10 to 20 years with their Parkinson's. If you get it in your 60s, usually it's more in that 20-year span. If you get it in your late 70s, 80s, it's usually more in that 10-year span. Well, what causes the hallucinations? The levodopa? Partly. You can have hallucinations even apart from the medication if the abnormal protein deposits that build up in Parkinson's settle in certain parts of the brain. And so you can have hallucinations even aside from the medications, but our medications that help our motor symptoms can increase the risk for hallucinations. So sometimes we might also back off some of our medications, like I was mentioning earlier, if hallucinations arise before we add that medication, pimavanserin, or brand name Nuplazid, I mentioned specifically for that. And then any medication to help with drooling, yes, it depends on the patient. There is a medication, glycopyrrolate, most commonly tried for drooling. That can affect cognition. So some of my older patients that have memory problems, we can also, this might sound weird, but we can do Botox injection, or I should say botulinum toxin injections, because it doesn't have to be that specific company. But those can be done to help with the drooling called sialorrhea that can happen with Parkinson's. And then connection between Parkinson's and autoimmune disease. Parkinson's is not considered an autoimmune disorder. So while there might be patients that have Parkinson's and an autoimmune disease, it is not considered one of those autoimmune diseases that makes you more prone to other autoimmune diseases. However, from COVID, it is something that can make your immune system a bit weaker. Parkinson's was included in people that could get their vaccines earlier as being somewhat immunocompromised, but there's not really a large clear connection between Parkinson's and autoimmune diseases.
Awesome. Well, we are out of time, but I'm going to put our information in the chat one more time in case anybody else has any other questions. But thank you, Dr. Christie.
Of course. Thank you, guys.